So at the outset, I'd like to thank the organizing committee for giving me this opportunity to be here to discuss a niche topic, genomic risk stratification to tailor radiation therapy. This slide were originally presented by Dr. Philip Portsman at the San Antonio Breast Cancer Symposium 2021. So, tailoring systemic therapy with genomic risk profile is quite well known to us, at least with the molecular classification that we have. We day in and day out tailor systemic therapy with these. Also, now the genomic risk stratifications, including the 21 gene panel, and there are several others which has been recommended and supported by several societies to tailor systemic therapies, but the same is not there with the radiation therapy. In essence, radiation acts like a drug, and there is a possibility that we could identify patients where RT is not always beneficial, or we can optimize the risk benefit ratio. The current RT standards, as we know, is sort of one size fits all criteria because there are some variations, but mostly the choices are not based on molecular or genomic basis. The volumes, the dose, and the indications are also varied across the centers. The initial attempts to identify whether the molecular classification could impact radiotherapy decisions was done by Danish Breast Cancer Cooperative Group, and they tried to evaluate the effect of ER/PR HER2 status on the role of post-mastectomy radiotherapy for breast cancer. They did find out that patients who are luminal A type extracted more benefit from radiotherapy as compared to triple negative and HER2 positive breast cancers. Recent analysis from the HERA trial also found that the patients with node negative did not benefit much from addition of locoregional radiotherapy. And in patients with 1 to 3 positive lymph node patients, there was definitely a decrease in the risk of locoregional recurrence, but the magnitude was lower than the historical studies. So with the changing, systemic therapies, the advancements and more effective systemic therapies, although the benefit is there, but the magnitude of benefit is also decreasing. And the similar is for triple negative breast cancer analysis patients, where it has been found that the effect of radiotherapy benefit is the lesser in magnitude. This was a study which tried to identify a genomic risk profile, which is known as adjuvant radiotherapy intensification classifier, where they included 27 genes. And then they applied it to the SWAG BCG91 RT trial, which was a node 0 breast cancer trial where BCS with or without radiation was given. And they found that in patients where radiotherapy was not given, in the patients with a low Arctic score versus a high Arctic score, the patients with a low Arctic score were more radiosensitive. They were derived more benefit in terms of locoregional recurrence as compared to high Arctic score. So based on this Arctic score classification, there is a sense that maybe patients with a high Arctic score, they demand more dose intensification in terms of either dose, volumes, or whatever it is. And in patients with low Arctic score, maybe there is a scope for a de-escalation of radiotherapy. So this is one of the signals. There are several ongoing trials which are evaluating the role of these genomic risk markers to tailor radiation therapy. One pioneering work was done by Jacob Scott, where they derived a GARD scoring, which is genome adapted radiotherapy dose, which is basically combining the linear quadratic model, several gene expressions based on radiosensitivity index, as well as the standard of care radiation dose. And they again found that in patients who are having a high GARD score, they are probably more radiosensitive. They have got better outcomes as compared to low GARD scoring. Subsequently, in last year, they also published their more results. And maybe it's the time we are beginning to understand that the curve for a particular patient with a particular dose is not always the same, and it may vary from patient to patient. Radiation-induced gene signatures, they are, yes, prognostic and predictive also, and they have been applied to identify pathological complete response, and it was found that they are predictive of death CR rates. Some signatures have also been tried to find out whether we can predict patients who are going to have early recurrence versus a patients who are going to have late recurrence, with implications on radiotherapy decision makings in the future. Pre-op radiotherapy in breast cancer, which is kind of making a comeback, and there are several studies evaluating it. This one study tried to again evaluate patients based on the MAP3 kinase 4, and they found that patients who had a low expression of MAP3 kinase 4, they derived more benefit in terms of distant metastasis-free survival in when treated with surgery plus radiotherapy. However, it is difficult to discern the direct effects of radiotherapy and breast cancer. More so, the interactions are getting complicated with advancements in systemic therapy. The RT effects require a long follow-up, and mostly because radiation is delivered in the adjuvant setting, the effect of radiotherapy immediately is not perceptible. It requires a long-term follow-up, and since the effects are not dramatic, there are few takers to take trials on this. There is, in a sense, opportunity to tailor all of these radiation therapy aspects based on the genomic risk profiles. Like, for example, whether all patients would require the similar target volumes, whether there are patients who can be chosen to de-escalate and escalate in terms of volume or dose. So finally, to conclude, molecular and genomic data guide systemic treatment in breast cancer, and molecular class does have varying effects with radiotherapy, as we have seen from the Dennis breast cancer group. The data are limited, but yes, there are promising data on radiogenomic signatures like ARTIC, which we discussed, and the GUARD scoring, and it suggests that tailoring is possible. At present, there is no validated biomarker which can reliably predict the benefit derived from radiation at the patient's level. But the future studies are ongoing and may incorporate genomic factors to guide radiotherapy decisions. So this is just for a food for thought. This is one of the studies that we did at our center where we evaluated XRCC1 gene polymorphism in head and neck cancer patients. Just to highlight that, yes, even in the routine practice in India, we have an opportunity to evaluate this and have outcomes where we found that patients who are having a wild variant versus a polymorphic variant, the polymorphic variant of XRCC1 had got more toxicities, but they also were having better outcomes. So patients who are having a polymorphic variant of XRCC1 maybe are good candidates for de-escalation of therapy in the future. So it's time that we move on from one size fits all to in the 21st century, where everything is made to measure, and so the radiotherapy decisions be. Thank you very much.